Ladies and gentlemen, you are so welcome to this afternoon's public lecture, Neurodivergence in Older Adults. We are so excited to be having this session with you guys today because this is probably one of the seminal times that this topic will be discussed in such an open forum. And to that end, I'm so proud to be welcoming Dr. Mary Doherty, who's a consultant anaesthetist at Our Lady's Hospital, Navan, and clinical associate professor at the School of Medicine, UCD. As a founder of Autistic Doctors International, Mary has brought together a vibrant community of autistic clinicians and aspiring doctors from across the world, with a focus on peer support, advocacy, research, and training. She developed the Autistic Space framework for meeting the needs of autistic people in healthcare settings and has co-authored multiple book chapters on autism. Her research interests include healthcare for autistic people, as well as experience and support for autistic medical students and doctors. Current projects include the experience of autistic psychiatrists, reasonable accommodations for autistic clinicians, and the healthcare needs of older autistic people. As a mother of two neurodivergent young people, Mary is passionate about optimizing mental and physical health for autistic people, and she believes that moving from traditional deficit framing of autism to a neurodiversity affirmative approach is the way forwards. I would ask you to welcome Mary, and we're looking forward to hearing what she has to say. Thank you, Mary.
Thanks so much. My slides have just come up. Okay, super. Thanks so much for the invitation. This is just so exciting to be having this conversation, here in Ireland. Finally, really, because I think there is a growing awareness of the needs of, older autistic adults internationally. I've been involved in autism research for a few years, and it's not that long ago that if a project was looking at, a late diagnosis of autism, that we're talking about teenagers, that was common enough up until quite recently. Whereas now, we know people are getting diagnoses right across the lifespan. So what I want to talk to you about today is a little bit. I'm going to give you an overview of some of the work that I've been involved in, and also just a mix of my own experiences as well. What I am going to talk about is Autistic Doctors International, because that's where a lot of the work that I do comes from. Take a look at the healthcare needs of older autistic people. I'll briefly touch on ADHD in later life, because neurodivergence is not just autism. Talk about the need to recognize autistic people, and that's patients, colleagues, loved ones, because so many of us that are in this field that have an interest in neurodivergence, it's because we have loved ones, who really need us to kind of move that conversation along away from that traditional core deficit framing. I'm going to talk to you about the Autistic Space framework, which is a framework that I've developed with two colleagues from Autistic Doctors International, which is a simple way that you can really remember and just conceptualize what the needs are of all autistic people in all sorts of settings. I look back on my own life, my own career, and think, gosh, if I had known years ago that I was autistic, things would have been just so different. But again, it's never too late. I've just managed to pull together all of the work that I've been doing recently into a PhD by publication, and that looks at the insights that autistic doctors can, and the insider perspectives that we have, and just how we can leverage that to improve healthcare for autistic people. And talking about ADI, Autistic Doctors International, this is our website. The membership criteria are to have a medical degree and to identify as autistic. So we don't, so self-identification is fine. And this is the leadership team. I started the group back in 2019, and we started with less than 10 members. Now, 6 years later, we have over 1,200 members spread across the world in all continents, including Antarctica, which I think is quite cool, especially because I'm a skier and a climber, and I'd love nothing more than to be spending a season in Antarctica. But anyway, I will not go off on that tangent, because I could and use my entire time talking about my own special interests. What I want to talk about is the kind of learning outcomes that we really need to move towards. We're not going to get there today, but this is the start of this journey. The goal is for all healthcare providers to become not just autism aware, but autism competent. And in the wider sense, the goal is for all autistic kids to have the opportunity to grow up confidently autistic. Again, we're not going to, get there today, but what I want to think about today is, what does it mean? Is it possible to become confidently autistic in later life for those of us who haven't had the opportunity to grow up confidently autistic? And why does it matter? And it absolutely does. And that's why I'm so thrilled to be having this conversation today. The Autistic Space Framework, I'll talk a little bit more about in a few minutes, but it was basically a descriptive acronym that really meets, in all sorts of settings, really what we need is a little bit extra space. But we've used that as an acronym to stand for sensory needs, predictability, acceptance, communication, and empathy. And we also talk about physical space, processing space, which is really processing time, and emotional space. Some of you may be familiar with this already. I'm hoping that you will become more and more familiar with it as it rolls out in more and more settings, healthcare settings, but also other settings, which I'll tell you about in a few minutes. We published it in the British Journal of Hospital Medicine. It's freely available. It's open access. You can use it. You can adapt it to your setting. So please have a look at that, and please feel free to download it, to use it, to adapt it to your own particular healthcare setting, or indeed other setting. We've written it up for social work, which is potentially relevant for geriatric medicine. And this was led by an autistic social worker, and we've published it in Practice, Social Work in Action. We've also just recently submitted for publication an adaptation for education. So hopefully that will be available soon. All of our work is available through our website or on our link tree. And that's just some of the stuff that we've done. We've written up the Autistic Space Framework for anaesthesia, and we do have a project in ADI to write it up for geriatric medicine as well. That's been ongoing for a while, so hopefully we'll see that sooner rather than later. And the thing about it is, as we look at healthcare providers across all fields, we didn't get any training. I certainly didn't get any training when I was going through med school, or indeed postgraduate training. And while that is increasing recently, it's still very nebulous what it means to be autistic for a lot of providers, and particularly because of the heterogeneity. We're all so different. There's such a range of ways of being autistic. So it can be kind of hard to figure out what it means, what are our needs, and in particular, what are the sort of things that we all share as autistic people. And that's really where the Autistic Space Framework came from. It was a way of trying to bring together all of those needs, because this framework can apply to any autistic person, no matter what their profile of strengths or needs might be. And, as I said, in healthcare settings, but also beyond healthcare as well. It's very useful for supporting autistic colleagues. So I do a lot of training around supporting autistic healthcare providers and medical students, and this is the framework that I use. So it's very versatile. For me, this is where it all started. These are my two munchkins. Some of you may have seen these two before, but it was only really when my son was diagnosed initially. He went through that assessment process from about the age of about 3 up to about 6, and like at that time, he's 17 now. He's towering over me, but at that time, 6 was considered to be a late diagnosis. Like, it's wild when you think back, and that's only a little over a decade ago. But the importance was that, even back then, my daughter identifies as neurodivergent, was struggling with mental health issues that she might not have needed to go through all of that if we had only understood when she was little what it meant for girls to be neurodivergent, but there was nothing known, back then. And what was known was very much that core deficit framing. What's wrong? How can we fix it? Whereas I have absolutely no doubt now, having, like, there's 14 years between the two of them, and how he's grown up in that neurodiversity affirmative paradigm, in contrast to that core deficit paradigm. And the difference in terms of outcome it's just phenomenal. And I see that replicated right across the autistic community. Kids who get the chance to grow up confidently autistic, they don't come out with the same battle scars that those of us who didn't have that chance had to go through. And then as I look back, through the family even further back. This, this was a photograph that was posted on that was printed on the front page of the Irish Times sometime back in the late 1990s. It was there was utter chaos, and because what happened was it was a bomb scare in Dublin. I don't remember the exact date or the circumstances. And this photo, the lady on the right, she was probably one of the people in this world that I loved the most, apart from my parents. She was an aunt who looked after me as when I was a toddler, when I was a baby, right, through my childhood. And the thing was, Cora, everyone in the family knew that Cora was very unusual, very unconventional. It's only now, 20 years after she's passed, that we realize she's obviously autistic. And I look back and I think how her life might have been different if we had known that, if that had been known. I think it would have been a lot easier. She would love the idea of, being here and, me talking about her and her life and, just being a part of advancing knowledge, medical knowledge. And it's very poignant for me as I look back and I look at that photo and I think, gosh, like the look of confusion, and very much it was the fact that her usual route, she did the same thing, every time she came up from down the country. She'd come up on the train, she'd get the bus from Houston, she'd get off at the quays outside what was McBurney's, and she would walk up O'Connell Street. And just the fact that her routine was suddenly disrupted, it was the amount of processing time that it took, looking back, and we didn't understand why she seemed to be, perseverating around what had happened for a long, long time. It's just processing, and now as I understand what it means for me to be autistic, I can so understand that. And even the way she's standing, that what she used to do this thing with her fingers, with her hands on the side of her neck. We didn't know that was stimming, So it's quite poignant for me looking back, and that's why I love the idea of, just talking about the needs of older autistic adults who just haven't been picked up, and how important it is that we start to recognise that. And luckily, there are loads of people recognising that now, and in particular, Anthony Hopkins is one of my favourites. But I love that quote from Stephanie Preissner, I don't have a defective version of what you've got. And we have to remember that's very much the dominant sort of narrative around autism, but we have to really move away from that. Again, looking back, this is not new. Like right back at the earliest days of science and medicine, some of the most innovative thinkers, in hindsight, we can't make a diagnosis posthumously, of course. But, once you get, I don't quote Hans Asperger often, and a lot of you will know why, but this quote's useful. Once one has learned to pay attention to the characteristics of autism, you realize they're not at all rare, and that's, so this is my life. All the time, I see autistic people. They often don't know they're autistic. Now, some do, but most people don't. And despite the current sort of, popular narrative around overdiagnosis, it's just nonsense, particularly for older autistic adults. We have to acknowledge that the one thing that we do know is that the vast majority of older autistic adults are unrecognized. This was some work from England, in the UK, showing that 9 out of 10 autistic people over 50 are undiagnosed. And that's, that's in a different jurisdiction where they have had an autism diagnostic pathway, they've had legislation, they've had increasing knowledge. They're years ahead of us in terms of the recognition, and still the vast majority there. So, here in Ireland, we're really only at the very, very tip of this iceberg. Now I want to briefly talk to you about this, my current study, which is with autistic psychiatrists. And I don't have time to tell you about the study itself, but just to say that there was 8 participants, it was a qualitative study, and one of the participants actually had been over 40 years in psychiatry and was retired, and only in retirement was really starting to explore what being autistic meant for them. And one of the others gave me some lovely case studies that I'm going to share with you in a minute. She was a specialist in old age psychiatry. In terms of recognizing older autistic patients, it's important to know whether or not you view the world yourself through a neurodivergent lens or through a neurotypical lens, because what the psychiatrists were saying was that they don't recognize themselves in training. And if they don't recognize themselves as autistic, how on earth can they recognize autistic patients? So that came through very strongly in terms of the research. So that's a bit of a challenge to think about. Could you possibly be neurodivergent and not know it? Yeah. So this was one of the cases, Maureen, in her mid-70s, as far as I remember. She was in residential care and her residential placement was at risk. She was seen as difficult. She was often in conflict with staff, residents, and then she got sick, physically ill, and was hospitalized. Then what happened was when she recovered, it was quite clear that she really wasn't welcome back. And then what happened was my participant was asked to see her on the ward. And what she said was, I walked in and thought, well, you're clearly autistic. Have people not realized this? But then she realized that when she spoke to other professionals that they had realized, but they had all felt too underqualified to say anything. And the thing was, it made such a difference because the staff then were able to get training. Everyone finally understood what was going on. She was welcome back. And most importantly, she finally realized that she wasn't broken. She was just autistic. And then the other one was a guy called Brendan. He was in residential home. He was in his late 80s. He was, as she said, not far from dying from chronic physical conditions. She'd been asked to see him about possible depression, but it turns out that it wasn't depression. It was that he thought he had failed at life. And he was seen as the really odd one in his family. And what she said was that just knowing that I recognized his type of person and that he might be autistic was a huge relief and comfort to him. He realized that he hadn't failed at life. There are others like him. And what she said was really poignant, that he likely died feeling much better about himself. And I think that's just such a powerful gift to be able to give to people, later in life. So that's why it's so important that we can just recognize autistic people. I'm not going to go into this in detail because of time, but just in terms of what is neurodiversity, we've just published a paper in Medical Education about the neurodiversity paradigm and what it all means. Important to recognize that it's not a synonym for autism. It's not a diagnosis. About 15, maybe 20% of the population are neurodivergent. And it's a range of conditions. Autism and ADHD, probably the most common, are commonly recognized, but also Tourette's. I don't have a diagnosis of Tourette's, but I'd absolutely meet the criteria. And the thing is, it's like autistic people are autistic, whether or not they have a diagnosis or whether or not, like if your life is set up in a way that to suit your the way you are in the world, and you're not in any overt difficulty, depending on how the diagnostic criteria are applied, you may or may not reach the arbitrary diagnostic threshold. You're still autistic. And then what happens for a lot of people who are managing okay, maybe through a very structured lifestyle, work pattern, then they retire. And that's when the wheels fall off, so things can get, or they get sick, that's when things can get really difficult. But again, co-occurrence is the norm. Most of us are multiply neurodivergent. I'm not going to talk about language. This is a webinar that I did for Lancet Cell Press that we took a deep dive into the language. But all I will say is use autism, not with autism. Use autistic, not with autism, and definitely not ASD or autism spectrum disorder, because we're not disordered, we're not diseased. We're just different. Disabled for sure, but not diseased or disordered. Prevalence probably 2, 3, 4, 5. Kids recently in Ireland, the most recent figure is 5%. And that's probably about right. It's going to be the same in across the lifespan. But again, most older autistic adults are, not at all recognized. Male to female, traditionally thought of as a male, almost exclusively male up until quite recently. Most recent figures 2 to 1. Some experts in the field would say that we're still missing autistic girls and women until we move closer to parity. Intellectual disability is a minority of autistic people, in contrast to what we've often traditionally been taught. There's still people out there saying that over half autistic people have an intellectual disability. That's not true. And most of the lost generation of autistic people are those who don't have a co-occurring intellectual disability. In psychiatric populations, much, much higher. And this is why it's so important that we reframe how we view autism and, move to that neurodiversity affirmative approach, particularly for the next generation, because the mental health outcomes for autistic adults are absolutely appalling. Up to 80% experiencing a co-occurring mental health psychiatric diagnosis. When people were screened, 10% of psychiatric inpatients, 20% of unselected new presentations to psychiatric outpatients. There was a study in Sweden. Most of these people are being missed. We know that we have the same issue here in Ireland, but most of these people are completely being missed. Very high prevalence amongst those who have died by suicide, also those who have been hospitalized after a suicide attempt. Homeless populations. Really high prevalence there. An association with gender diversity. ADHD, huge amount of co-occurrence. I mean, experts in the field would say up to 70% co-occurrence in both directions. Particularly with autistic, with people, women who have been misdiagnosed with borderline personality disorder or emotionally unstable personality disorders, huge degree of misdiagnosis and missed autism diagnosis in that group. This was from a survey of our own members, so autistic doctors. Not going to go through it in detail, except to say one thing, that considering autism to be a disorder, which was a minority of our members, but that was associated with a preference for the term doctors with autism. It was also associated with having attempted suicide. So again, there's lots of ways you could view that, but I think that really does show, it validates in my view, the idea that a neurodiversity affirmative approach is protective in terms of mental health, which is the view of a lot of it's the view of autistic psychiatrists overall in general, that we really need to be moving towards preventing mental illness for a lot of autistic people. Now, I'm not saying it can all mental illness can be prevented, but I think a lot of it can. But we also need to think about the co-occurring physical issues, which are only recently being recognized. There's a lot of medically unexplained symptoms, ME, chronic fatigue, chronic pain is increased for autistic and neurodivergent people, POTS, mast cell activation syndrome. There's an association with long COVID. So neurodivergent people are more likely to experience long COVID. The relative risk is like 1.4. What's going on there? Joint hypermobility, Ehlers-Danlos, recently recognized, and just very important to think about. As we age, menopause has a huge impact on sensory changes, but also on executive functioning and lots of other aspects. As my sight changes as I age, I'm finding that my light sensitivity is getting much, much worse. My noise sensitivity is getting a bit better as I'm getting deaf. But again, I can't manage that well because I can't tolerate anything touching my ears. I really struggle. I need hearing aids, but I really struggle to tolerate them. So that's something that I'm moving towards. Parkinson's, arthritis, pain. There's an increased association with mobility problems and increased falls. And then there's rehabilitation challenges, because the last thing we want as autistic people is strangers coming into the world that we have set up within our own homes. There is definitely an association with premature mortality. And we looked at that with some barriers to healthcare research that we did. I'm not going to go through it in detail, except to say that we found that barriers to healthcare, such as even simple things like difficulty using the phone, were associated with adverse health outcomes. And as well as difficulties with the phone, a lot of autistic respondents, over half the respondents, said that they avoided or delayed a needed GP visit due to not feeling understood. And so much of that is because of a lack of training. I talk about that interview that I did for the Times. I talk about, some of my own difficulties in terms of accessing healthcare. But the consequences were really stark, 70% with a mental health condition untreated. A third of the autistic group reporting a potentially serious or life-threatening condition that they didn't access healthcare for. These are really serious consequences to having healthcare that's inaccessible. Interestingly, we found no difference between self-identified or formally diagnosed autistic respondents. And this one I'm not going to go through, except to say that this was from the second paper from that project, which was the qualitative work. And when we looked at this was basically the stories behind the statistics that we reported in the first paper. And we found a really plausible pathway from those early barriers to healthcare avoidance and serious adverse outcomes. They're open access, so do feel free to have a look. What do we know about older autistic adults? Not nearly enough is the reality. There is good evidence of reduced life expectancy across various populations from various countries. Now, it's important to say that that's a group effect. It's certainly not predictive of any individual outcome. And as somebody who has passed what was relatively recently considered, the average lifespan of an autistic person, to 54 years of age. I mean, that's scary, Like, this was in a population where the average life expectancy was 70. A 16-year mortality gap for autistic people without an intellectual disability. With an intellectual disability, that was like 30-year gap. Utterly shocking. There is good evidence for increased prevalence in most mental health conditions. There's mixed evidence in terms of the differences in cognitive decline. What's going on with Parkinson's disease? Why do we have there was a recent study showing a six-fold increase in Parkinson's. What's that about? We definitely need so much more research on this. I'm not going to get into the details, but there doesn't seem to be a genetic link between autism and Parkinson's, so it's hard to know what's going on. Some of more recent work might suggest some overlaps in terms of recognizing movement differences amongst autistic people. So that's a very confusing picture at the moment. We just need so much more research. Same with dementia. What do we know? Not an awful lot. This was very recent. This was only published last week. Looking at intellectual disabilities and dementia and autism. But again, we really don't know. The evidence is very mixed. There is definitely an association with intellectual disability for sure, but there's probably no increase in prevalence or acceleration of cognitive decline for autistic adults without intellectual disability. But what about menopause? This is a fabulous paper because menopause is such a milestone for so many people. And, as this paper is titled, When My Autism Broke, and that is the sort of experience that a lot of people really do describe, And like if you're working in memory clinics, for example, how confident are you to pick up ADHD? What does ADHD look like in later life? We just have there's so much that we need to look at. Residential care, is another massive area that I'm not going to go into now. But again, it's somewhere where the autistic space framework can be applied. Sensory needs. I'm just going to show you one photograph. I'll show you this one first. This was a chat I was having with an orthopedic surgeon in Navan. We were just outside the theatre, and he was asking me what it was like to be autistic, and I was going, well, for example, I'm struggling to focus on our chat because of the noise from the air handling unit above our heads. I have to actively focus. You might just filter it out. And he just went, what noise? Yeah, I hadn't even heard it, And yet I would be battling that all day, every day in my daily work and life. That's 75 decibels. I took that photo after he'd gone, so there's no voices there. That was just the background noise. The other one that I struggle with is light. I didn't take this photo, but when I saw this, I recognized that in the way that you might say recognize a caricature, And imagine what it's like to be sick and to be trying to access healthcare as an older autistic adult, if that's how you're experiencing the environment. It's really, really tricky. And the consequences can be fairly stark. This is a paper that I had published in The Lancet quite recently, where I'm describing a meltdown where I lost access to speech. Purely because of the sensory environment, and like as a doctor, maybe getting published in The Lancet is kind of the holy grail, but maybe not for one of my most shameful experiences. But anyway, there's another one coming up soon, so I'll balance it out. But I do that because it's important for people to realize the impact, I think, of sensory needs, particularly. And predictability, again, just how important it is to have that predictability. And as I say, we see it there with what happened to Cora on that day. And acceptance, the core of my message, just that neurodiversity affirmative approach. and how that plays out in older life is recognizing monotropism, recognizing the importance of, our passionate interests, and our unconventional hobbies, and making space for that within, like, our residential care services, for example, and how easy that can be to make such a massive difference for somebody, and also recognizing the need for, restorative solitude. I mean, the idea of being in a nursing home and having to have communal meals and, like group activity, it's just hideous as an autistic person, but it's hard to understand that, I think, if without understanding the autistic experience. Um, we can't be expecting autistic people to adapt to environments designed for the non-autistic majority. All I'll say about communication is that if you're not autistic, communication with us is not intuitive. If it seems to be, maybe have a look at some of the screening tools for yourself. Empathy, I'll skip this one. Empathy is the idea that we don't have empathy is the most damaging myth about autistic people. It's complete nonsense. It's just absolutely not true at all. And again, just going back to the psychiatry study, the one other thing that I wanted to show you is the idea of masking and how the idea of, not realizing who you are throughout your entire life and trying to present, trying to meet this apparent neuronormative standard, um, that's just destroys us internally. And to get to the end of a life and suddenly realize it can be the most validating experience. And I think that's the greatest gift that we can give to our older autistic adults. We can't be waiting for the psychiatry world to meet this need in terms of, assessment and diagnosis. The capacity just isn't there. So I think we really need to just acknowledge this issue and just take the reins and do it ourselves. I'll finish there. Just by saying that we absolutely need evidence-based care for older autistic adults. That negative framing, it just perpetuates stigma and shame. Never, ever too late to recognize and reframe autism. And familiarity with the autistic world is what's needed. And then the autistic space framework for accommodations. Before I completely finish, I'm just going to remind you of the framework, and I'm going to ask you, could you possibly implement this? Would this help? How could you see this helping with your patients? And if you think it might, can you please evaluate the outcome? Because what we need to do is we need to build the evidence base for this. There's my contact details. Do feel free to get in touch, and I'll leave it at that. Thanks so much.
Oh my good giddy aunt. Everything, I could listen to you all day, and you have touched so many elements. I can see so many patients. I can see my own home life. I can see my dear father, who was like Brendan, and we always just thought he was just odd and never understood that he was actually quite neurodivergent. But thank you so much for that, Mary. I'm sure there's a lot of emotion online and with people thinking about all that you've shared. So I'm just going to give you a moment to regroup, and we have some questions coming in. I'm just going to introduce our panel. So first of all, we have Florence Horsman-Hogan, who is the reason that we're here today, because she asked that we could do this. And I think we had said before we set up, we probably need a whole day of this, and I think that is absolutely correct. So I'm just going to introduce the panel. So Florence is a nurse, and she started in healthcare in 1983 as a nurse in paediatrics, acute care and older person services. And since 2009, she's worked in older persons residential care facility in South County Dublin. Initially as a nurse manager and then as the quality and patient safety manager. She holds a master's in healthcare ethics and law and a master's in nursing in advanced leadership from the Royal College of Surgeons, and she's a fellow of the Faculty of Nursing RCSI. And she was diagnosed as an autistic person in 2023 and continually strives through public speaking and national forums to advocate for the autistic community and to promote the considerable assets autistic people and neurodivergent people bring to healthcare. And if you follow LinkedIn or any social media, you will see her there. And Ruth Connolly is a clinical psychologist and principal psychology manager with the Muriosa Foundation. Ruth has a particular interest in neurodiversity and autistic experience. Over the past 25 years, Ruth has been involved in the provision of psychological support to autistic children and adults with co-occurring intellectual disabilities. This work has included supporting late diagnostic autistic adults with high support needs to move from institutionalized settings to homes in ordinary community settings. And last but not least, Sheehan describes herself as a very late diagnosed autistic elder woman at 70, though her doctor father did try to tell her that when she was 47. She's retired now, but she was a tour guide, she further education teacher, she worked in the media, and she has degrees in archaeology and arts history, an MA in 1994, history research diploma, fascinated by art, history, psychology, media, and all things print, and she retired in 2008. So I'd like to introduce the panel, and I'm going to start off with asking Ruth, if you don't mind. Ruth, you said that you could share clinical experiences of identifying and supporting older autistic adults presenting in disability services. Could you give us an example of that?
I can indeed. I mentioned, you mentioned there in the bio that we have been involved in the decongregation of institutional settings. And in the course of that work, I would say about 90% of the people who were referred for psychological supports and mental health supports were people with intellectual disabilities who had not been diagnosed as autistic and instead had collected a variety of diagnoses through their life. Things like schizophrenia and personality disorder, bipolar disorder, and kind of labels like the difficult woman, the difficult person. And what we found is it's never too late to diagnose and to identify, and an understanding of a person's experience of the world changes everything in providing the right supports. So the lost generation are out there. They're in intellectual disability services and mental health services and all around us in every profession. What we found, the themes that we found were traumatic life stories. We found really high rates of multi-class polypharmacy, years of institutionalization in settings where often the treatments were high doses of antipsychotic medication, restrictive practices like human rights restrictions, restraint, seclusion. 30% of autistic people are non-speaking or minimally speaking, and the majority of the people that we work with were never provided with augmentative or alternative communication systems. And people who were using language, their language was seen as disordered rather than different, and therefore their life experience often wasn't understood. I suppose on the positive side is what we've learned is, Luke Bearden, who's an autistic researcher, talks about autism plus environment equals outcome. And that's certainly been our experience. When we adapt environments and get the right environments for people, the social environment and the physical environment, so the right people, the right setting, the right adaptations, it can be absolutely transformative. And we've had the privilege of being able to transform many lives. And we would have lots of stories that would be nice to share at a future date.
Thank you. I think, Florence, you've shared on social media about your own dear mum. Are you happy to share about that here?
About my mother?
Yeah.
Yeah. So my mother was 48 when she had me, and she was diagnosed with chronic paranoid schizophrenia. Now I didn't live with them a lot because I was in home for a while, but I think I was with them for about 5-6 years. I've never known her to be paranoid a day in her life, but she was a very, very kind woman. And in those days, in the, say, late 60s, early 70s, there'd be a lot of traveling community wandering around Ireland, and I'd come home from school and she would have, sound is gone?
No, we can hear.
Sorry.
Keep on.
Okay, so she would have some random stranger sitting beside the fireplace having tea, bread and jam, and she'd be listening to them chatting.
Did you feel that she was misdiagnosed? I think you shared that before.
Looking back now, no, but now definitely, yeah, because she wasn't paranoid. She didn't talk to herself in multiple voices. She didn't hear multiple voices in her head. What she did do was, when she was very stressed, she would list literally about 10 or 15 generations back. We're a very old family. She'd list all of their names when she was really stressed, and she'd walk up and down the street or up and down the road.
Okay.
And the more stressed she was, the more she'd do it. And that is when she would be brought into, she also had, always had about 14 cats in the house, plus kittens. But they were the times then she would be brought by the guards into, I'd say that would make you paranoid, into St. Bridget's, the local psychiatric hospital, and she got ECT and she was knocked out with psychotropic medication. So even though she was, I actually never knew her because she was so doped out with psychotropic medication.
And do you think if it was today, she would have had a different diagnosis? Would she have been neurodivergent?
Well, I don't know, Deirdre. I mean, when you consider 22 years ago, I was diagnosed borderline personality disorder. I only had 3 of the 5 criteria, and one of those was suicidal ideation. I had 4 suicide attempts. 2 of them landed me in ICU and into the psychiatric services. And then I had emotional dysregulation. The black and white thinking in borderline is usually you hate somebody or you love them. My black and white thinking was it's either right or it's either wrong. But then when I was diagnosed in 2023, my psychiatric consultant did apologize. But now I've spent since then, trying to come off psychotropic medication and learn to be myself without having my affect blunted, which is extremely difficult. So I don't know if Mammy would be diagnosed, or would the psychiatric services still hold on to her as a schizophrenic. I can't answer that because, as Mary earlier on said, we don't know enough about it. But looking at the woman, she didn't exhibit signs of schizophrenia, but she possibly could end up with a diagnosis of borderline, or I don't know.
I'll move on to Una and just ask Una, based on your lived experience, because you've told us you were only diagnosed at 70.
Yes, it was really funny, actually, though it turned out later on that my parents both knew. In 2016, in December, my sister told me about the child of somebody we both knew that was recently diagnosed as autistic. And I said, what's that? And she was trained as a teacher, and she said, look it up, find out about it. And I thought that was quite interesting. So anyway, I went off and I found this book, Chantal Cecile Kira's book, Everything Basically You Want to Know About Autism, Spectrum Disorders, Complete Guide. So I read that, and I came to page 18 and 19, which had a list of signs and symptoms. And by the time I got down to the bottom of the second page, I thought, my God, that looks familiar. And then it was like looking at a mirror. I thought, my God, that's really like me. So anyway, there was a link in the back of the book. It was full of resources and books and so on. And there was a link to the Baron-Cohen test. So I took a deep breath and I did the Baron-Cohen test. And sure enough, of course, I was over the line. 39, which out of 50, which isn't much, but it's over the line. So I explored it further. And later on, Baron-Cohen did a Channel 4 live program called How Autistic Are You? And if anybody logged on, they could be assessed roughly by his team. So out of 500,000, was 480,000 people, there were about 70 or 80,000 that got a little email back saying, inquire further. So I got one of those.
Could I just ask you, Una, because I haven't been familiar with Baron-Cohen. What's that now?
Professor Simon Baron-Cohen, who Mary met recently and put up a lovely photograph meeting of him, he set up the Cambridge Autism Centre for the study of autism. And a lot of his work is really quite foundational. Some people would argue now with what he said, but I mean, back then, 10, 20 years ago, it was really crucial. But basically, he devised a test of 50 questions that were a test of autistic traits, basically, and the average score was 18, and then 30, double that, 36 would be you're getting into people who are kind of highly autonomous, really. I call it the autonomy test now. So I kind of give it to friends and say, how autonomous are you actually? But once you get over 40, 40, 45, it begins to look as if you're actually autistic. So I thought, right, I've got those two. So I went to my GP and she poo-pooed it and said, oh, you're 70, you've passed so far, you've got, multiple degrees and qualifications and blah, blah, blah. You couldn't possibly be. So that was kind of frustrating. So I kept looking online. And I found there was a Trinity was doing a conference in Tala about the genome of autism, the genes associated with that. So I got onto them immediately and I barracked my way onto it. They said, oh, this is only for young people in mid-20s. I said, listen, I'm 70 years old. I'm in a hurry. I want to know. This is reality testing. I'm not getting fancy here. I'm just saying I really want to know because it sure looks like me and I really want to know. Anyway, somebody called Louise, who may have been Professor Louise O'Reilly, got me on the phone and we had a conversation and basically she ended up agreeing. Long story short, I went to that meeting in February 2019 and I met Mary there. Actually, she was on the same table. I now know that she was a plant. Professor O'Reilly had put her there beside me to check me out. And I asked Mary, she was using the phrase autistic community, okay? And in the conference, on the one side of the room, there were people who were autistic, okay, or neurodivergent, you say now. And on the other side, there were plenty of researchers who were sharing their results with autistic people, among them whom would be both, researcher and neurodivergent very well. So I caught Mary by the sleeve and I said, was that a figure of speech? Is there actually a real autism community? And afterwards she said, Una, that was a really autistic question. Is this literally true or metaphorically true, or am I missing something? So anyway, she said, give me your email and I'll link you in to a website, which was extant at that time, Autistic Paddies. And there you will meet, people. So I got onto that. I went to a meetup. And the first questions I was asked by Joan MacDonald was, what are you looking for exactly? Because there are not many people of your age or whatever. And I said, I'm looking for diagnosis, reality testing. And within 5 weeks, I was invited for an interview with someone who was doing a project on female autism. And they were she was desperately looking for an elder. So I said, right, I'm your woman. So for 2 hours, rigorously, I was tested up, down, the proper interview, the tests, the photos, the stories, the whole 9 yards. After which she, Liesl put up her hand and said, that's enough now. I think there's no doubt that you really are, and you want a cup of tea. Have you suffered much? And I kind of laughed because I was just so relieved. It really answered a lot of questions about me over my lifetime. And then I was kind of thrilled. I thought, gosh, this is a very small, special thing. That's really great. And then I actually had a whiplash moment because somebody close to me who I said, why the hell didn't you tell me? And he said, there's no cure, which of course is the reality, slamming on the brakes moment. There isn't. And I suppose all my life long, I'd always been looking for answers to things that I experienced that seemed to be different from other people. And I thought, why am I different? And then I remembered I had a sort of a meltdown, shutdown, breakthrough, whatever you call it, when I was 24. And I met Professor Ivor Brown and he said, there, it's just your nerves, And anyway, I had kind of therapy and group sessions and the whole 9 yards, and I kind of came through it. And then, and I was in Jungian psychoanalysis for a year with a person who said, you're very single-minded, was the nearest she got, but she said, you're not schizophrenic, but you're definitely very single-minded, i.e. monotropic. And then in the mid-90s, when I was back in Ireland, my dad took me aside, brought me into the study. He was a doctor, as was my mother, and said, now, Una, that this thing called Asperger syndrome. And I said, oh, what's that? And he tried to explain by illustrating the story of a dentist friend of ours that I knew, who was great fun and very interesting, quirky kind of individuality person. And then, unfortunately, he applied an old medical label, which was infantile autism. infantile schizophrenia rather, which would have been extant when he was in training.
Mm.
At which I jumped up and I said, "Oh, don't be silly, Dad. Now, if there's one conversation I would like to have back in my life, it was that one." Because I should have said to him, I was an analyst for a year. An analyst told me, "Go away, you're not schizophrenic, out of the question, whatever." And also, forensic psychiatrist Dr. Brian McCaffrey once said to me, "Oh, get out of here, you're not crazy." He should have said, though, I would have preferred if he said, "You're as classic a case of Asperger's as I've ever seen in my life. Go away, read a book about it, you're all right," just a bit eccentric, just a bit different. So my father had an aunt who was non-verbal, and I remember meeting her as a child in the mid-50s when my grandparents came up to Dublin after they retired from teaching. And she communicated with sign language, and I remember being fascinated by her. She was a great dressmaker, and was very witty, kind of looking and agile and interesting person. And she's buried with them in Dean's Grange. But I do wonder whether she was non-verbal autistic now. And there were certain traits I saw around me, shall we say, that could be classified as really very autonomous or really quite characteristic, really, of autistic behavior. Anyway, both my parents were doctors. My mum kept a book of observations, both about me and my elder brother when we were children. Then later children came on, another brother, and then twins later on. So she kind of lost track. But I don't know where those books went, but she made very careful observations of our development as children. And she was, of course, a working doctor. They worked together. So, when I look around back, when you say that, Florence, that you say that your aunt was reciting, the family genealogy, one of my brothers, his hobby for 40 years has been genealogy, and he could really tell you about this stuff like for generations and generations. And so I expect, that it was already there. There was lots of soldiering, lots of barging around battlefields, lots of scientists, all that kind of stuff. So it's really not that surprising. But to me, it was the most tremendous relief to know that I had this kind of quirky thing that is there to produce human diversity. That's really, I think, one of the
Isn't that
things that it's
gorgeous?
for,
Yeah.
actually, to allow to be diversify. It's like the other speaker of a stereo system. You can only get that when you've got two speakers interplaying till you hit the sweet spot that gives you stereo. I think really, our thing is like about that.
You're
And the
so you're
second,
so eloquent in how you describe it, Una. I'm
well,
just
yeah,
wondering though, because so many of us in healthcare meet neurodivergent people on a daily
yes,
basis. And
yes,
something that Mary said to me was, imagine someone coming into your home the way you have it, and they
yeah,
are having to do communal dining in a nursing
yeah,
home.
yeah,
And we don't think about those things. And we have a question into the chat, which is,
yeah,
Mary, thanks for the presentation. And as researchers, how do we
absolutely, Mary.
access older adults who are neurodivergent when so many are unaware or not diagnosed? So that's an interesting question, because how can we help the community of people who are neurodivergent if they don't even know they're neurodivergent, so we can't actually access them? So has anybody got any thoughts on that? Mary, perhaps?
Yeah, I think there's a lot of research happening internationally where maybe the awareness has started, a couple of years back, a decade or two ago. So there is a community of, aware autistic adults who are willing and able to take part in research, and that's really helpful. And obviously, the research that comes from communities elsewhere, we can apply here in Ireland, I think. But we can screen also. There's some really good screening tools. I like the AQ that was mentioned earlier, the autism quotient. But I also like another one, which is the RITVO RADS. And that's particularly useful because it picks up things that we've maybe learned to accommodate for or learned to change in adulthood. So it looks at childhood features as well. So RITVO RADS, and that's the one way that's the kind of project that we need to do, because the only way to get funding and services in place really is to produce data. So there was a great program, a great project which screened new presentations to psychiatric clinics, screen them for ADHD. And that is what was the start of the ADHD program, I think, here in Ireland. We really need to do the same for autistic adults. But again, we need to be not thinking in terms of one or the other. We need to be looking at a, combined neurodivergent pathway, I think, developmental pathway.
I'm just going to prompt people if there's any more questions to put them into the chat, but I'd just like to ask each one of you individually in a couple of sentences, 15 words per sentence for you, Florence. What would your message to the health community through the IGS be? So I might start with you, because I don't want to be putting people on the spot, but Mary, what would your message be? What is your wish from starting this conversation now with this public lecture? What would your wish for the health community to start doing, or what's the blue sky?
Yeah, I want every healthcare professional to be autism competent and to feel that sense of confidence that they can identify autistic people coming to them. And just to be clear, that autistic patients means autistic people who are coming to healthcare because they're sick. We're not patients just because we're autistic, just to put that out there to be clear.
Absolutely.
Just become confident in recognizing and meeting the needs of autistic people. And you can use the autistic space framework to do that. Also, consider your own positionality, because if you're autistic and you don't recognize that, then people coming to you describing a really standard list of autistic features and experiences, you're going to say, oh, that's like me. I'm not autistic. Therefore, you're not autistic. So that's what was coming through from the psychiatry paper, and then people talk about the guilt when they consider all the patients over the years that they've missed. But it's really important to recognize we do the best we can with the knowledge we have in the moment. And then when you know better, you do better. That classic Maya Angelou.
Love that.
You just learn as much as you can about autism and about autistic people from autistic people. And in particular, I think it can be helpful as autistic professionals, autistic healthcare professionals. Yeah, look at our
Thank you.
work.
Florence, I'll go to you next, and it's great that I can have the banter with you and tease you.
Yeah, I think first of all, the IGS is doing one of the most important steps, which is putting out awareness of this, because first of all, we have to shove out awareness there so that people know. And then I think particularly not psychiatric services need to be, my consultant said they're going to be reviewing female cases like mine now to see, could it be an autism diagnosis? Because I learned from psychiatric services, they have to give you a diagnosis to discharge you. And when I was being diagnosed, they put in borderline personality disorder. And I only learned 20 years later that that was only ever a working diagnosis because I didn't fit the criteria. I only found that out when I was diagnosed with autism. But at least I got an apology, but the consultant said they're going to be reviewing the cases. So I think that's what needs to happen, is find the autistics, find us in the community. And the researchers should be able, well, I know LinkedIn is a great source for contacting people, and a lot of us autistics are very good at getting out on social media and shoving out our information. And we get people back who are saying, oh, I might be autistic. So we're all raising awareness. I think that's one brilliant thing about the autistic community. Once we get our hands on something, we're out there in force with the facts, the figures, looking for the data and trying to pull as many people together as possible. And I think, as we maybe mentioned earlier on today, a full day discussion on this, pulling in all of the health services, the disability services, the psychiatric services, the older person services, and the acute care services, pulling everyone in to a day of awareness for this. And just quickly, I'm going to say there is a HSE Land video coming out. It's a HSE Land module on neurodiversity, hopefully in the next couple of weeks.
Brilliant. Thanks so much. Ruth, I'll come to you next.
Yeah, I have very strong views on this. I suppose that the most important thing is to listen to autistic voices. And as Mary said, any training, awareness, needs to be centered on autistic experience, because for many years, training has focused on looking at autism from the outside in. So looking at behaviors and deeming them somehow deficits, or, a neurotypical person, acting in a difficult way, when actually the only way to understand autism is from the inside, autistic experience and a different way of being in the world. So instead of trying to make people fit a system, we need to change the system, and we need to change that radically. And I think we need to look at really good quality, co-produced and co-delivered neurodiversity affirming training. And I think there's lots of really great work going on out there, but probably less so for older adult services. I mean, my understanding is less than 1% of the research in autism research is devoted to over 50s. So exciting things to come. We've started doing some of that work in an adult disability service. And it's kind of mind-blowing for people when they hear, from autistic people what autistic experience is like.
That's fantastic. And Una?
Recognition is the main thing. That's why I bring my, my as I am ID card with me all the time, and my sunflower disabilities thing, because that people recognize that. I was recognized in Vincent's when I broke my leg, and Mary helped me out with that too, but they recognized immediately the ID card. So access to health services was brilliant, perfect in that instance, and I was really delighted by it,
Good. So we're going to wrap up. We're near at 4 o'clock. I just want to say thank you so much, Mary. I could have listened to you all day. Thank you to each and every one of you for your contribution. Thank you, Florence, for asking us to host this in the very first place. And I do think that this is a conversation that needs to continue. It has been enlightening, and I have seen so much in what you've said. So I hope to be a neurodiversity champion. Is that something I can hope to be? I need to figure out am I neurodiverse myself. My children would probably say so. So thank you so much for your time, and we hope that this public lecture gets lots of traction and lots of people get to see it and to learn. Thank you so much.
You're very welcome.
Thank you.